Hello everyone, I am Gorordo and welcome back to the session number 6 of the World Sepsis Congress Spotlight. This session is entitled Update on Adjunctive Sepsis and COVID-19 Therapies. And we are about to start with Dr. Evangelos Giamarellos, who is a professor in internal medicine and director of infectious disease at the National Kapodistrian University of Athens and Medical School in Greece, and also president of the Hellenic Institute for the Study of Sepsis and chairman of the European Sepsis Alliance. Thank you very much, Dr. Evangelos, for your presentation.
Well, thank you very much for your kind words. Thanks the organizers for inviting me to discuss about Anakinra treatment and which COVID-19 patients benefit the most from this treatment. This is my conflict of interest disclosure for this presentation. And before going on with my data, I would like to remind to all of you that Kineret, the trade name of Anakinra, was approved since 17th of December 2021 for the treatment of adults with COVID-19 pneumonia. And actually, this is considered quite an achievement if you see at this statistics. This is a search of clinicaltrials.gov as of 15th of December 2021. And you see that by that time point, we had more than 7,000 trials that have been registered. And actually, all these are trials of both vaccines and monoclonals and drugs for hospitalized patients. And by that date, the only drugs that were registered by the European Medicines Agency, approved and European, were 3 vaccines, 3 monoclonals, and for the management of hospitalized patients, remdesivir, dexamethasone, tocilizumab, and Anakinra. And this is quite astonishing because also it demonstrates how difficult and how complex the problem that we're dealing in is. Because as a matter of fact, we have from more than 7,000 trials, only 4 drugs for hospitalized patients being registered. And this is just a few months from now. So, although we consider COVID-19 to be a homogeneous disorder, as a matter of fact, it is extremely heterogeneous. And not all patients are the same, but however, we insist to consider that all the patients are the same. Imagine that in this circle are the patients who arrive at the emergencies of hospital. However, not all of them are at risk. And as a matter of fact, for all the patients, we deliver to them exactly the same treatment. And as a matter of fact, there are 2 end-ups, 2 probable outcomes for this patient. The first patient is the patient who arrives at hospital. He's in need of oxygen. He deteriorates into severe respiratory failure. He ends up in the ventilator, and there is a great risk for death. The other scenario is that the patient, although he is discharged from hospital, is just phenomenally well. However, there is persistence of symptoms, work absenteeism, loss of productivity, and long-term morbidity and mortality. So what is another approach? Another approach is to stop treating patients in a horizontal way, but try to understand what are the personalized needs of each and every one. In other terms, from those who are in this circle, to recognize those who are at risk and to start immediate treatment. But when someone listens to at risks, what he has in mind is that he's in need of a type of biomarker that can tell who are the patients who will deteriorate. And of course, if this is the case, we need to focus on it. This is part of the truth. The real truth is that we don't want the biomarker not to tell us who's the patient who's at risk, but to inform us on the pathway leading the patient to it. In other terms, to administer a treatment which is tailored for the needs of this patient in order to decrease mortality, decrease admission in the ICU, and improve cure rate. So allow me to acquaint you what is happening for patients at COVID-19. This is the virus which is bound on the receptor, and as a result of this, the virus is internalized in the lung epithelial cells. The epithelial cells are destroyed through the release of danger-associated molecular pathogens. There are 2 big groups two big families of danger-associated molecular patterns in the lung tissue. The first is Al1Alpha. This is stuck on the cell membrane on epithelial cells, and it's released when epithelial cells are destroyed by the virus. The other dumps are intracellular constituents of our epithelial cells. The most common is calprotectin. These are released and they stimulate the production of Al1 beta. Al1 alpha and Al1 beta, they act on their membrane, on their receptor, which is embedded on the cell membrane of the alveolar macrophage. And as a result of this, we have a pro-inflammatory reaction. However, the same cell is producing an endogenous antagonist which bounds on the receptor so that the effect of Al1 alpha and Al1 beta is a bit attenuated. So what we are in need? We are in need of a strategy, a personalized strategy for which we have delivered the acronym SAFE. In other terms, for patients who are with pneumonia, who are in need of either high flow or low flow oxygen, and who have concentrations of a biomarker with the acronym SUPAR, 6 nanogram or more, these are the patients for which the biomarker can tell us that they are under the attack of Al1 alpha and Al1 beta. Once we see that the biomarker is increased, we need immediately to start treatment with a biological that can scavenge both Al1 alpha and Al1 beta. And this exists, is the recombinant form of the endogenous antagonist of the receptor, for which I was previously talked to you about, and the name of the drug is Anakinra. These are data from the beginning of the pandemic. You see that at time 0, on the time of the admission of the patients at hospital, we measured for them the biomarker SUPAR. The acronym stands for soluble urokinase plasminogen activator receptor. And you see that the patients who have concentrations at the emergencies, well before any sign of ARDS appears, 6 or more, the next 14 days, day by day, they end up in the ventilator. And these data were further confirmed by 2 independent cohorts, one from 352 patients, another of more than 2,000 diabetic patients, showing that indeed, at the time of hospital admission, SUPAR can discriminate the patients who are at risk to deteriorate. Somebody else may ask, okay, what are the advantages of SUPAR? Could I have a biomarker that can give me exactly the same information in case when I live in a setting where SUPAR is not available? Actually, the advantage of SUPAR is that it integrates information coming from D-dimers, CRP, ferritin, IL-6. We know that all 4 of them are increased in our patients, but not all of them are increased at the same level. In other terms, if you integrate information which is coming from each of these 4 biomarkers, you end up with a predictive capacity similar to SUPAR. And with these 4 biomarkers, we form another score, which we call that scope score, and can give the same information on SUPAR. Let me go then back to what the SUPAR or the scope score is helping us. So from the moment we identify that, you start treatment with Anakinra. And you see that in this phase 2 open label trial, that patients who receive standard of care and on top of Anakinra, they're doing extremely better until day 14 compared to patients receiving only standard of care. There is a 30% decrease of the risk to end up in the ventilator or to die. And this, of course, is translated to huge survival benefit. With this in mind, we addressed, when we had the results of this phase 2 trial, to the European Medicines Agency, and we received advice on how to design and conduct a pivotal phase 3 randomized clinical trial, which we published last October at Nature Medicine. This is the design of the trial, exactly the same population, patients randomized into treatment with placebo plus standard of care or Anakinra plus standard of care, and standard of care contained dexamethasone, and the primary endpoint was the allocation to the 11th strata of the WHO CPS. This is the primary endpoint, and actually what you see as an endpoint is an odds ratio, a ratio that can tell you what are the chances to be allocated to a worse outcome if you receive Anakinra compared to if you receive placebo. How this worse outcome is different. In other terms, a patient after 11 days may belong to one of these colors. He may be either at gray, which means that the infection is fully resolved, or in green, which means that he remains at long COVID, or in yellow, which means that he remains hospitalized in the ward, or in orange, which means that he remains hospitalized in the ICU, or red, which means that unfortunately he has died. So the risk to be the worst outcome compared to placebo is 0.36, which means in overall 64% benefit coming from Anakinra treatment. And if we would like to focus on the two edges of the spectrum of the outcome, the one spectrum is to be fully resolved, fully cured, and this is increased by 64% with Anakinra, or to remain at a critical state or being dead, and Anakinra treatment offers a 54% protection. Someone may ask, but it's a biological. It has adverse events. Here is the comparison of the emergence of serious treatment adverse events. And as you see, treatment with Anakinra was protected. It was protected from serious infections and particularly from VAT. Why that? Because if the patient is protected to be admitted in the ICU and be ventilated, then the incidence of ventilator-associated pneumonia will go down. So in other terms, with the current standard of care for this type of patients, if we have 2 patients who will be fully recovered, we manage to increase them to 5 if we add Anakinra. If we have 1 patient who's asymptomatic but remains PCR positive, we increase them to 3 if we add Anakinra. If we have 5 patients at long COVID, we decrease them to 3 with Anakinra. If we have 2 patients hospitalized, either in the ward or in the ICU, we decrease them by 50%. And if we have 2 patients who have died, we manage to save 1 of them from death. And then you may ask me, what is the positioning of the drug? This is the course of the patient towards the ICU. At the beginning, you have a viral response, which is characterized by symptoms where drugs like monoclonals or Piravir are positioned there. Then patients progress into the pulmonary phase. They are admitted in the ward. They have decreased respiratory ratio, but not that much to lead them to the ARDS, and all of a sudden, the patient is in need of ventilation. He is admitted in the ICU. There he has ARDS or shock or renal failure. Both these categories of patients are in need of dexamethasone. Tocilizumab, the trials have shown that it's positioned when there are organ failures. But for patients who are at risk to progress and to be admitted from the general ward to the ICU, we need to screen all of them, either with SUPOL or with the 4 biomarkers which frame the scope score. And if these are increased, then we need immediately to trust our biomarker to save the patient from ICU admission and to give them Anakinra. And with this approach, you see that the numbers needed to treat to achieve cure are 4, to avoid being severe or death are 15, and this is equivalent to the treatment benefit of the more severe patients that tocilizumab provides. Thank you very much for your attention, and I'm looking forward to the discussion.
Thank you very much, Dr. Evangelos Giamarellos. I have a couple of questions. You already answered how to select a patient that is a candidate to have this treatment with Anakinra, like the SAVE strategy, SUPO, and the other scores. And which one would you use, or what's your criteria for starting this treatment in general patients with COVID? Is there an early warning system to say this patient will benefit more or something?
The only way is for patients who are admitted with pneumonia at the emergencies, all of them, irrespective of what blood gases are telling, to screen them either for the 4 biomarkers of the scope score or with SUPAR. And if SUPAR is increased or the scope score is 6 or more, we need to start immediately treating. you know very well, and we know all of us very well, that what is really bizarre with this virus is that the virus is not waiting. All of a sudden, the patient deteriorates, and this is unpredictable. We have now a tool that tells us who's the patient who will get deteriorate. We need to trust her. We need to start treatment based on the biomarker and not to wait for clinical signs to present. Then it will be too late. We need to change a bit our mind. I understand that this is a bit different than the traditional approach, but early treatment is the only way to avoid the heterogeneity of the ICU, to avoid all these discussions that we have the last 1.5 years. What are we doing if the patient is at a critical stage? The best approach is to avoid the patient to progress into critical illness. And this is the only way.
Thank you. And another question is, do you think that this line of drugs like Anakinra will soon be used for another infection or another agents, another viral or bacterial that generates sepsis? Are we close to use it?
My impression is that since we have this paradigm of early identification of the pro-inflammatory reaction, which will deteriorate the patient, we need to start trials with this frame of mind to use biomarker to tell us from the world for patients with borderline infections, who are those who will deteriorate and replicate the same approach. I believe that this is the future approach to go. In the ICU, the heterogeneity is far too high, and it will become more and more difficult to help them with immunotherapy.
Well, thank you very much, Dr. Evangelos Giamarellos. And we're going to continue with this session number 6. And I will introduce you now to Professor Alexander Vlaar. He is in the Department of Intensive Care Medicine in Amsterdam, UMC in the Netherlands, and is a researcher, a well-known researcher in this field. Thank you very much, Dr. Alexander Vlaar, for your kind presentation, and the audience is all yours.
Thank you very much, and it's a pleasure to present here, and thanks again for the invitation. I'm thrilled to share with you for the first time at a conference the phase 3 results of Vilobelimab in severe COVID-19. These are my conflicts of interest. So, of course, I would have hoped that COVID-19 would be part of the past, but we all know it's part of the present and the future. The mortality rates remain high. 30 to 60% of patients admitted to the ICU, the severe critically ill patients, are at risk of dying. And this remains. I'm an intensivist myself, and in the last weeks, I still had to admit patients to the ICU with severe COVID-19. And it remains because a part of the patients are not willing to be vaccinated, a part of the people worldwide are not able to receive a vaccine. And of course, we also still have the immune compromised patient that may still develop severe COVID-19. And what we know right now, and actually already from the beginning, that there's a key role for complement in the development of severe COVID-19. And what do we have, which was also already shown by the previous presenter? We have, when the patient is admitted to the ICU and is becoming critically ill, we have really limited options, except of supportive care, the dexamethasone, of course, but just level 2A evidence to add tocilizumab on top of the treatment. And again, we have a high mortality still in this patient category. So complement in COVID-19 is a key role, and especially for C5a. It is associated with endothelial damage. C5a is known to activate neutrophils, result in release of tissue factor, and in the end leads to microangiopathy with thrombosis. All features of severe COVID-19 in which complement may drive this. And what we have right now is a first-in-class anti-C5a monoclonal antibody, Vilobelimab, which binds very specific high affinity to epitope it blocks C5a up to 100%. And what is very important to understand and remember is, in comparison with other complement inhibitors more upstream, C5a is totally downstream, and it leaves intact the C5b9, the MEC, the membrane attack complex, which may prevent onset of supra-infections, which is the case with other complement inhibitors. So it has a very nice safety profile. So I will, in a few minutes, present the phase 3 results, but it was part of an adaptive phase 2-3 design. So we first investigated in a phase 2 whether it's safe to administer Vilobelimab in severe COVID-19 patients, but also to see what is the best design regarding endpoint. So what we enrolled were early intubated or dependent on oxygen at the ward patient COVID-19, with a primary endpoint on PF ratio at day 5. At that time, we thought it would be a proper endpoint. We also had secondary endpoints on 28-day mortality and, of course, again, the safety. So what did we show? We showed it's safe in severe COVID-19 patient to administer Vilobelimab. We had no more side effects, also no more supra-infection, but the PF ratio is not the proper endpoint. And what we know right now about the disease of COVID-19, that we have a lot of thrombotic complications in the pulmonary compartment, which results in perfusion, ventilation mismatches. And if you improve the perfusion, it may in the end result in a deterioration of your PF ratio, while the patient actually is doing better. So the PF ratio is not a proper endpoint. That's what we learned. What we did see, however, was a 50% lower all-cause mortality rate in the Vilobelimab treatment arm, which was supported also with other endpoints on organ failure. So Vilobelimab had really a strong signal in towards better outcome. Again, what we knew already, but it was good to confirm, is that C5a is highly activated in severe COVID-19 and that Vilobelimab is very well able to control C5a levels in COVID-19. So that was the first step, and that made also the phase 3 trial in which we finally ended up with the 28-day all-cause mortality as primary endpoint. The other thing we learned from the phase 2 is that the effect was most present in the severely critically ill COVID-19 patients. That's also why we made the inclusion criteria only critically ill intubated patients, however, early in their ICU setting, so within 48 hours of intubation, patients were enrolled, with key secondary endpoints assessed as well. So here we go. The results. The baseline characteristics, here you see it's 369 patients enrolled, quite well balanced. It was randomized, of course. The only thing what is good to remark is on the WHO scale, you see that there is a trend towards some more patients in the 7 scale in the placebo group, which is important to remember because with the predefined secondary endpoints, I will come back to that. Also very important, also for me as an intensivist, is how representative is this patient population for me at the bedside when I'm treating patients? Well, it's very representative. Almost 100% of the patients received corticosteroids, and also a significant part of the patients, 20%, received tocilizumab or kind of immunomodulators in this setting. So primary endpoint, 28-day all-cause mortality, Vilobelimab, 31.7% mortality, and placebo, 41% mortality, which was site stratified, which I will come up on the next slide. What does it mean? It means it has a clinical meaningful benefit with 1 additional life save for every 10 Vilobelimab treated participants, a very important finding. However, this was site stratified with a p-value of 0.09. So why is it important to stress this out? There was an FDA request while the original protocol-defined analysis had no stratification. They requested, because of the guidelines, if you randomize by site, that you should also do the analysis stratification by site. However, this model does not correct for very small sites properly, and also not with low enrollment, and especially not if there is an imbalance between the patients receiving placebo and Vilobelimab. And here in this trial, there were relatively a few small sites with only 1 or 2 enrollments, with also preferable placebo by accident in this setting, which was by coincidence. And if you go back to the per protocol original defined analysis, it is significant. And also all other approaches you could do in a post hoc setting were significant. There were also 9 patients missing for the endpoints in both arms. If we do multiple imputation, again, it is strongly significant. So if we go and for the 60-day mortality, again, the impact of Vilobelimab remains. So it is a really long-term effect. We are really saving patients. So Vilobelimab on 60-day has a 36.5 mortality compared to placebo 47.2 mortality. So 1 additional life was saved for every 9 patients treated with Vilobelimab. Again, the p-value in a per site stratification analysis is 0.08. But if we do the analysis supplementary, I showed also for the 28-day, again, it hits strong significance. We had pre-specified subgroup analysis. We looked in the Western Europe group, and here we had a huge effect, a 43% relative reduction in 28-day mortality on top of standard care, including dexamethasone, tocilizumab. So in Western Europe, we had 1 additional life saved for every 6 patients treated at day 28 and every 7 patients at day 60, again, on top of standard care. And here, what I mentioned already at the baseline, it's important to remember that there seemed to be a bit of imbalance, but then if we, in a pre-specified subgroup analysis, analyze for the more severe patient with a baseline ordinal scale of 7 or a baseline AODS severe with a PF ratio below 100, or the patient with already renal failure, all those secondary endpoints, subgroup pre-specified, are strongly significant in favor of Vilobelimab. Also for kidney failure and the need for renal replacement, again, we show that Vilobelimab is superior to placebo. And again, what is very important to see what the safety profile is of Vilobelimab. And here is what we see is that there is no increase in infections or adverse events. And again, this is also because Vilobelimab preserves the MAC. So we have no difference in infection compared to other complement inhibitors in COVID-19 trials, which had a negative effect on secondary infections. But again, with Vilobelimab, we have a very nice safety profile. So if we go to the summary, for the primary endpoint of 28-day all-cause mortality, Vilobelimab demonstrated a clinical meaningful benefit. Pre-specified and post-hoc analysis suggests robust reduction in mortality at day 28 and day 60 in Vilobelimab-treated patients compared to placebo. We had a significant treatment benefit in predefined analysis of Western European patient population with a 43% relative reduction in 28-day all-cause mortality on top of standard care. Significant treatment benefit in all 3 predefined subgroup analysis of patients with higher disease severity at baseline. And again, a favorable safety profile for Vilobelimab confirmed in this critically ill patient population. For me, as a physician and intensivist, personally, Vilobelimab should be considered as a new additional treatment option in intubated COVID-19 patients, pending approval, of course, of the authorities. And also, these data suggest that we need future research, and there is a possible role for Vilobelimab in the treatment of non-COVID-19 ARDS patients. Of course, it was a huge team effort, and I would like to thank everyone who made it possible to have this trial done and has this clinical and significant and meaningful impact for patient care in severe COVID-19 patients in the ICU. Thank you very much.
Thank you very much, Dr. Alexander Vlaar. We have a few questions, and I will ask everyone to not forget to place your questions in the box below. So the first question is, you talked about coagulopathies and risk. So we have to select patients who are not to receive based on the risk of thrombosis or something like that. That's a question for you.
No, so the patients were also allowed when they had an increased risk of thrombosis. So there was no selection for that.
Okay, good. And the other question is, you already said that this is for recently intubated patients, but do you consider, me as an emergency physician, would like to use some drug to prevent the mechanical ventilation required? So you think this drug will be something that we can use to prevent intubation and mechanical ventilation?
So I think there could be definitely also an opportunity there. But again, what I stated, that despite all the things we try to prevent patients being admitted, they are still enrolling in the ICU. So this is also an area where we need to improve the outcome, because with a mortality now between 30 and 60% in the ICU, it is really a huge problem. And although maybe the world has the idea COVID-19 has passed already, I'm just faced in my ICU, in my shifts, still with patients being admitted. So there is still a huge problem.
Yes, and the last question, do you think this drug and this line of drugs could be used in other disease and other agents like bacterials? I'm thinking gram-positive or gram-negative resistance infections.
Yeah, so I think there will be definitely a place also in other areas, so other viral pneumoniae, other forms of ARDS, and bacterial definitely as well. I think what will be key is to have a proper patient selection, to have it more homogeneous. Yeah. I think we did very well here with the adaptive design, that we first did a phase 2 to identify really the patients where probably the most benefit could be investigated. And I think this is also a learning lesson for sepsis trials, ARDS trials, that we really need first to find our specific patient group where there is a treatment effect, and then start doing the phase 3 trials. And I think in the past, too often, we just wanted to have a large trial where we enrolled any sepsis, any COVID, or any ARDS patient. And I think this points out where we should go with trials in ARDS and sepsis.
Well, thank you very much for your kind presentation. It was enlightening for a lot of us. And we're going to move on with the next presentation. The next speaker is Luregn Schlapbach. Thank you very much, Luregn, for your participation here. You're a doctor, a pediatrician doctor in pediatric intensive care and neonatal intensive care ICU in the University Children's Hospital in Zurich. Thank you very much. We're pleased to hear you.
Dear colleagues, thank you so much for the opportunity to talk about the pediatric aspect here, focusing on immunomodulatory adjunctive therapies in children with sepsis. I have no disclosures to make. What we'll try to go through in the next roughly 10 minutes are some aspects in terms of pathophysiology and biology as to why children are different. We will discuss some theoretical implications in terms of the dysregulated host response to infection. And we'll use this then actually to see is what have we actually learned from COVID-19 and multisystem inflammatory syndrome associated with COVID-19 before we talk about sepsis. The reason for this approach is that actually at the moment, the evidence base for immunomodulation in children with sepsis is still very scarce. So we will mainly focus on guidelines on hydrocortisone, but then as well, expand to novel immunomodulatory approaches, which currently are being tested. So if you look at the 2020 Surviving Sepsis Campaign guidelines, they recommend, similar as to adults, to initially develop a bundle consisting of blood cultures, start antibiotics, start fluid boluses, and consider inotropes. If you look at the incidence, actually then sepsis is a relatively common disease and mortality is very low. However, if you look at patients which actually have received initial sepsis bundle and which are in shock that is refractory to this initial treatment, then mortality goes up dramatically, with, depending on studies, between 1 in 6 to 1 in 4 children that will still die. So reaching that stage of sort of refractory sepsis to initial resuscitation, remains a very high mortality disease, and such is a major problem. And the therapeutic options we have available at the moment for this setting are very scarce. So the question really is, how do I identify these children and what sort of treatment would we use? I think what's key to keep in mind is that the majority of sepsis cases in children happen in children younger than 5 years of age, a substantial proportions as well in young infants. And this is a phase of particular vulnerability due to the maturing immune system. And what you can see here is actually showing the development of the immune system is almost oppositely mirroring, the decrease in sepsis incident depending with age. It starts with the maturation of neutrophil function and T and B cell function until, at the age of about 1 year, you then have increasing response to polysaccharide antigens. And so during that time, of course, different defense mechanisms are important in addition to those that are relevant for adults. What's key as well for pediatric age groups is that sepsis-related deaths in children are primarily fulminant events. And as you can see here on the left side, we chose survival curves of patients that have died with sepsis. As you can see, is that almost 3/4 of pediatric sepsis deaths in previously healthy children happen as early as 48 hours after admission to ICU. So we see a much earlier pattern of death. And this is important to realize that as well, the dynamics between pro and anti-inflammatory response system in children may be different. And as we know that early deaths are more commonly actually harbored by, massive cytokine storm, the overwhelming activation of the immune system with damaging to the host, that later on we see stronger features of immune paralysis, but this is more common in children with comorbidities. But the key question, if we want to design personalized immunomodulation for sepsis, is actually that we consider actually how can we tackle the dysregulated host response to infection, which leads to organ dysfunction. And at the moment, our understanding of this host response remains extremely limited. And it is probably naive to propose that there is sort of one dysregulated host response, because we could imagine, if we look at the severity axis from no organ dysfunction to single multi-organ dysfunction, that there may be different types of dysregulated response to bacterial infection as opposed to viral infection. And there is as well dysregulated responses to other entities such as MISC. And in this context, I think it's key and as well, considering just the previous speakers, it's absolutely impressive to see how quickly the adult intensive care world has been able to generate high quality data on thousands of patients on highly personalized interventions. And there is a real risk that actually pediatric medicine will not benefit from this boost associated with the pandemic, because obviously we've had much smaller numbers. However, there are certain areas where actually the pediatric discipline has had unique benefits, and I think these are key when you think of future more personalized therapeutic option. And this essentially was the discovery of MISC as a new disease, which has led to very quick global learning with an unprecedented speed of data acquisition, and as well now, through the recovery study as well, a rapid pragmatic randomized trial. And that's probably where we should head in the future. Because within roughly 2 years of the discovery of PIMS-TS, we now are close to see release of randomized trial results. And we know as well that based on the BATS trial, that what clinicians have been doing at the beginning of the pandemic is they almost randomly use different immunomodulatory therapies, as you can see here. And I suspect if we would make that graph for children with sepsis, we would see something very similar. A lot of clinicians use glucocorticosteroids at variable rates. IVIG is not recommended anymore as a default, but is still being used. But at this stage, we have extremely few additional immune modulatory options available. What we know from MISC, and again, these are data which were published within roughly a year of the beginning of the pandemic, is we know from 3 studies that it is likely beneficial to use steroids, but it is not clear whether steroids are superior to IVIG or whether a combination is consistently better. So if we now translate this back to the sepsis guidelines, then as you can see, between 2002, 2017, 2020, the wording of use of immune modulation in sepsis actually is still quite vague. In 2002, the question was, is a patient considered to be at risk of adrenal insufficiency, then give hydrocortisone? Later on, this was changed to consider hydrocortisone, and based on the available evidence, which I'm just going to show you, in 2020, there was no advice given. Essentially, the guidelines stated give or do not give hydrocortisone for respiratory shock. The recommendation states that this should be considered if fluid resuscitation vasopressor therapies are not able to restore hemodynamic stability, but there is no recommendation given on this. And the reason for this is that different to adults, there are no large-scale, high-quality RCTs available until now. This recommendation is based on an aggregated odds ratio of 1.33. As you can see, it crosses the confidence line based on the 3 small RCTs with a total of 116 patients. So, and potential for harm as well, seen in some of the other outcomes. So this has clearly informed the need for a large RCT, which has been started in Canada and the United States, but which will recruit globally, led by Qus Mignon and Jared Zimmerman. This is called the Stress Hydrocortisone Pediatric Septic Shock Trial. But I think this trial is expected to give us as well new information, because the trial leads, they plan as well to look at markers that may tell us more accurately which patients are more likely to have benefit or which patients are more likely to harm from hydrocortisone. And this is based on the work which Hector Wong published over 5 years ago. As you may know, Hector Wong sadly passed away at the beginning of this year. But this study essentially provided a proof of concept that out of a heterogeneous sepsis cohort, we should be able on one side to enrich patients, patient groups for patients that have a high risk on one side to have a poor outcome, but at the same time as well to enrich patients for those that are more likely to benefit from a certain intervention, and then we should prioritize these interventions to them. Other than hydrocortisone, there is actually only very scarce data available, and as I mentioned, only scarce options for other adjuncts. The sepsis guidelines do not recommend IVIG based on a very large RCT newborns, which did not show any benefit. If any patients are likely to benefit from IVIG, these would be newborns. However, there remains a potential benefit in toxic shock syndrome. For plasma exchange, this is being used at some certain centers, in particular for patients with TAMOF, where there is possibility of benefit, but based on low-grade evidence. And other potential adjuncts, such as renal replacement or ECMO, should be considered. What has gained a lot of attention in adults as well as in children, as you know, is the use of high-dose ascorbic acid combined with hydrocortisone. For children at the moment, the only available data was published by Eric Wald and colleagues, which used propensity matching, which showed that patients in ICU with septic shock, which were treated with hydrocortisone, ascorbic acid, and thiamine, had substantially lower mortality compared to those that only had hydrocortisone controls. And this is being actually supported by recent findings. This on the right side graph shows you data which are currently under review, that shows you that vitamin C levels in serum in critically ill children are low and actually are associated with severity, both at time of admission to ICU, but as well as them becoming sicker in the next 24 hours. And in children as well in adults, the use of high doses of vitamin C at doses much higher than the doses which were used in the currently published controversial RCTs in adults, which largely did not show a benefit of vitamin C. Then the safety of the intervention suggests that much higher doses potentially could be used safely. And recent interest for this area has been increased again by a systematic network analysis from Rinaldo Bellomo, Tomoko Fuji, and colleagues, which showed that there is potential benefit of very high doses of vitamin C combined with hydrocortisone in adults. Plus as well animal data which show that megadose vitamin C has the potential actually to decrease the pathophysiology of gram-negative sepsis. This is where we currently are at. If you compare, however, what's happening in children, then out of the vast opportunities for immunomodulating agents, the main trials which are on the way, including Mark Hall, Joe Corsillo, focus on GM-CCF, and we actually at this stage, lack trials on other interventions to what I'm aware of. But I'm sure that it is urgent actually that we do want to take these trials, because at the moment I think there's a strong promise that as well for children we use targeted intervention that targets specific areas of dysregulated immune response, and that in the future we may have much better biomarkers to quickly identify patients more likely to benefit. But I think we do need to have a skepticism towards magic bullets. The key challenge in this field is, of course, what should the threshold be? Because of the speed of pediatric sepsis deaths is important. We can apply this very quickly. And the key question, of course, is, well, how can we actually identify trigger for treatments that can then be rapidly deployed, which are applicable not only to high, but as well to middle or long-term setting. And here again, to close the loop with COVID, I think the opportunity here really is that we do need to leverage of global collaborations to develop personalized interventions, which can modulate the dysregulated host response to infection. Thank you for your attention.
Thank you very much, Dr. Luregn-Schlapbach. And we have a couple of questions here at the chat. They're asking if you, what's your opinion on those sepsis cocktails with steroids and vitamins and vitamin C and other mixed treatments in children's, especially in neonatal population?
Okay, so at the moment, we do not have high quality RCT data. We have just finished a pilot study, which should be out for publication soon. So I cannot comment on that yet, but I think it's fair to say at this stage, we do not know. We do know that children potentially could be more susceptible to vitamin C deficiency because of the rapid growth rate they're in, nutritional deficiencies, and as well as I have shown, children with sepsis and septic shock are severely vitamin C deficient. The question, of course, is if it did not work in adults, would it work in children? So I think it's important that future trials do not repeat necessarily the same dosing that adults use, to consider higher dose of vitamin C. Plus, as well, based on the network meta-analysis, there is no benefit of thiamine. So if at all such trials would be considered, I would strongly suggest that such treatment is not given outside trials, and that a design will focus mainly on hydrocortisone and ascorbic acid.
Thank you. And
we do not know.
Okay. Yeah. As an adult intensivist, I think same. What do you think about the role of so-called precision medicine in sepsis? How would this impact in sepsis care in the future for children?
I mean, this is the desirable path that we should take. I think the challenge is, if we want to have precision medicine, that means we need to have markers which are very quickly available, which tell us very quickly which type of treatment should be favored. And at the moment, I think that is not the case for many markers. A potential candidate is actually ferritin. Ferritin, which has been used a lot around MISC, has been shown to be quite promising actually to identify certain subgroups of TAMOF patients, as Joe Corsillo's work has shown. Another potential marker are certain gene expression markers, which currently are being translated to point-of-care platforms, so they may become much quicker available in the future.
Okay, thank you very much. That's enlightening especially for those that we do not treat pediatric patients, and I think it's very useful to compare adults and pediatric evidence to learn about our mistakes, of course. Thank you very much, Dr. Luregn-Schlapbach.
Thank you.
And now we're heading to the last topic, the last presentation of this session, number 6, who is in charge of Dr. Sasson. She's a clinical immunologist and an immunopathologist and head of the Diagnostic Flow Cytometry at the NSW Health Pathology ICP-MR at Westmead Hospital in Sydney, Australia. this is a pre-recorded session, and maybe we can save your questions for her. Thank you very much.
Hello, my name is Dr. Sarah Sasson, and I'll be speaking on the approach to immunomodulatory and adjunctive therapy in adults with sepsis, and I thank the organisers for the opportunity to present. I'll cover the landmark corticosteroid trials in sepsis and lessons we've learnt from the last 2 years dealing with COVID-19. I'll touch on the concept of sepsis endotypes and finish with some current and frontier immunomodulatory sepsis trials. So we know sepsis is a life-threatening syndrome characterised by organ dysfunction caused by dysregulated immune response to infection, and it remains the most common cause of death in hospitalised patients. Despite decades of research, current treatments remain supportive, including IV fluids, vasopressors, oxygen, and antimicrobials. The panel on the right show our current understanding and model of sepsis. The left-hand third show likely predisposing host factors such as advanced age, genetics, environment, epigenetics, comorbidities, and the microbiome. In the central panel, the sepsis syndrome is characterized both by a state of hyperinflammation, but also a compensatory anti-inflammatory response syndrome. And then in the final third, we know that even patients who survive their septic insult and are discharged from hospital remain at risk for increased mortality and secondary infection out to at least 6 months. And so the excess inflammation of sepsis is mediated by pro-inflammatory cytokines such as TNF, IL-6, IL-12 and interferons, but also components of the innate immune response, including netosis and pyroptosis, and disorders of coagulation leading, for example, to DIC. On the other side of the scales, the immunosuppression can be mediated by regulatory factors such as interleukin-10, the IL-1 receptor agonist, and TGF-beta, but also heightened apoptosis of lymphocytes and T-cell exhaustion, for example, through the upregulation of checkpoint molecules such as PD-1. And this compensatory anti-inflammatory response may predispose to ongoing secondary infection. So given what we know about the myriad of ways that patients can present with sepsis and this underlying variability in their own host vulnerability and these two sides of inflammation and immunosuppression, there's unlikely to be on the horizon a silver bullet treatment for all sepsis presentations in the near future. But what we are seeing is increasing interest in understanding the individual baseline risk factors and taking a more personalized medicine approach for the advancement of precision immunotherapies. So I'll move now to cover some of the landmark corticosteroid trials in sepsis. So prior to 2002, there were findings that short courses of high-dose steroids did not improve clinical outcome in sepsis. But at this time, Anane et al. In JAMA published on a trial of 300 adult patients with septic shock, and they were interested in whether patients had evidence of a relative adrenal insufficiency and whether corticosteroids could go some way to improving this. That is, to give steroids at lower doses for longer periods. So they administered in one arm hydrocortisone 50 micrograms QID and fludrocortisone 50 micrograms daily for 7 days versus placebo. And the primary endpoint was survival at 28 days. They included all comers for sepsis, and each patient underwent a short corticotropin test prior to randomization. So on the right panel, we see that the primary endpoint did reach significance, with steroid treatment improving mortality at 28 days. And when the cohort was split into those that didn't respond to corticotropin, the top panel, the finding was even more significant. And in those without relative adrenal insufficiency or corticotropin responders, there was no significant difference seen. And in fact, 77% of enrolled patients fell into the top group of non-responders. In terms of secondary endpoint, the steroid treatment was also associated with reduced time to vasopressor discontinuation, both in all patients as shown on the right and in the non-responders to corticotropin shown in the top left. And again, no difference was seen in the corticotropin responders in the bottom left. So the authors concluded that there was the potential for one life to be saved for every 7 patients treated, and they also reported no significant rise in steroid-associated adverse events. So by 2008, hydrocortisone was actually being widely used in patients with septic shock who had hypotension and who were non-responsive on a corticotropin test. And this study, published by Sprung et al. In the New England Journal, was a trial comparing IV hydrocortisone QID for 5 days to placebo, and the primary outcome was death among patients who were corticotropin non-responsive. So in the left panel, we see that hydrocortisone did not improve survival at 28 days in all patients, or in the corticotropin non-responders, or even in the responders. But on the right, we see there was a reduction in the time to resolution of shock in all patients, and also in the corticotropin responders, which was interesting because that's actually going in the opposite direction of the original study by Anane that I showed you. So following that, in 2008, Anane published again in the New England Journal on the APROCUS study. This was adult patients with septic shock diagnosed less than 24 hours, enrolled in an RCT of steroids versus placebo. And this time, the primary outcome was extended to all-cause mortality at 98 days, so around 3 months instead of 1 month. And here on the left, we see that the primary endpoint was met, with steroids reducing 90-day mortality by around 6%, so 43% versus 49%. There were also significant additional findings showing steroids reduced time to wean vasopressors, time to wean mechanical ventilation, and time to reach a SOFA score less than 6. And finally, in the same year, Venkatesh et al. Published in the New England Journal with the adrenal trial, which again enrolled patients with septic shock within 24 hours and randomized to corticosteroids versus placebo, and had the same primary outcome of all-cause mortality at 90 days. And this study had the opposite finding, that steroid treatment did not improve 90-day mortality in all patients, but there were some significant secondary findings, including a reduction in the resolution of shock, faster resolution of mechanical ventilation, earlier discharge from ICU, and a lower proportion receiving blood transfusion. So reflecting on what the steroid trials have shown us is that there's really not replicable agreement that corticosteroids reduce mortality in septic shock patients at either 1 or 3 months, but certainly across the trials there were a number of the trend was that a number of secondary endpoints did reach significance. So it's interesting to then compare the decades of work in the general sepsis field to what's been happening in the last 2 years, with a very specific example of respiratory sepsis, that being COVID-19. So this is a summary figure put together by Dr. Priyanka Hastek at the Kirby Institute, just illustrating in the alveoli some of the immunomodulatory therapies that have made it through efficacy trials and are now in clinical use. And they include engineered monoclonal antibodies such as sotrovimab, antivirals, dexamethasone, and the anti-IL-6 agents such as siltuximab. And we were so fortunate to have the REMAP-CAP group already established, and they were able to use their infrastructure to really expedite the trial of a number of investigative agents through clinical trial and to advance them into clinical use. So here in blue, you can see that hydrocortisone efficacy was clearly demonstrated along with the anti-IL-6 agents such as tocilizumab and therapeutic heparin in moderate disease, whereas on the left-hand side of the plot, we see that some of the earlier antiviral agents as well as convalescent plasma did not reach efficacy. And the agent that came later was the JAK inhibitor baricitinib, and this was published by Marconi et al. In the Lancet, and they showed the efficacy of baricitinib, which was regardless of prior steroid use, regardless of prior remdesivir use, and independent of sex or disease duration or age. So it's interesting to reflect on why we're seeing so many immunomodulatory therapies make it into clinical use in COVID, but not so much in generalized sepsis. And we've talked a little bit about how that could be to do with the heterogeneity of the pathogens being encountered in generalized sepsis, but also I wanted to raise this concept of sepsis endotypes and the heterogeneity of the host response, both in terms of their baseline risk factors for getting severe infections, but also in how their cells and their systems respond to the septic insult. So this paper by Davenport et al. Looked at peripheral blood mononuclear cell gene expression, so that's RNA transcriptome, in a train and test cohort of respiratory sepsis patients requiring ICU. And what they found was two distinct sepsis response signatures denoted SRS1 and SRS2, based just on 7 genes, which are listed on the slide. And 41% of the cohort was categorized as SRS1, and these patients had an immunosuppressed phenotype characterized by T-cell exhaustion. And if you look to the right, they had increased mortality over the first 2 weeks with a hazard ratio of 2.4, and that was evident in both the train and then the test module. And just moving finally to some frontier trials in immunomodulatory agents. So it was noted quite early in the COVID-19 pandemic that lymphopenia associated with poor outcomes. So these are all patients that had COVID-19 disease, and those who died are shown in blue, and those with severe disease that survived are in black, and those with moderate disease who survived are in red. And you can see that plotting the lymphocyte counts actually stratified the patients on the basis of disease. So on the back of this kind of work and other investigations into therapeutic recombinant human interleukin-7, compassionate access was given to 12 patients with severe COVID-19 and associated lymphopenia. And in the top right, you can see the IL-7 treated patients show a rise in their absolute lymphocyte number. And in the bottom right, the patients who survived and were treated with IL-7 had the highest lymphocyte count, and this was higher than those who were treated and did not survive, or either of the control groups. And acknowledging this is exploratory work involving small numbers, but the trend was towards a lower mortality at 38 days and a lower rate of secondary infections. So overall, today we've reviewed the results from large corticosteroid trials in sepsis that delivered heterogeneous outcomes, particularly in regard to mortality, and therefore corticosteroids are not currently standard of care for sepsis, although may have some smaller secondary gain. We've looked at the rapid advancements of immunomodulatory therapy in COVID-19 pandemic in this particular type of respiratory sepsis, and look towards the future at more data emerging on the sepsis endotypes, because this may really have some interesting implications for prognosis of disease and the development of new treatments and identification of new treatment targets. The IL-7 is currently, the trials are underway in multi-center trials in USA, France, and Australia, and other agents under investigation include GM-CSF, interferon gamma, pooled immunoglobulin mesenchymal stem cells, and the checkpoint inhibitor anti-PD-1. So what will we see in the years to come? Well, it looks like there will probably be a trend away from broad protocolized interventions for all kinds of sepsis, and probably further research looking into organism-specific or patient-specific personalized medicine, and hopefully some of these will be biomarker-led modules. And it's hoped that this more patient-specific and personalized medicine approach will lead to further greater advancements in sepsis for our patients. Thank you.
Thank you very much for your presentation. And now we head to the end of this session number 6 that was called the update on adjunctive therapies and sepsis and COVID-19 therapies in the World Sepsis Congress Spotlight 2022. I would like to thank all the sponsors and all the organizations that helped spread the word about the World Sepsis Congress Spotlight in your communities. Do not forget to share on Facebook, Twitter, Instagram, any other social network you use. And remember, the sessions will be released weekly based on the World Sepsis Day and the Global Sepsis Alliance social media for those who wish to rewatch and share with your colleagues. I'm Luis Gorordo. I'm very thankful with you for your participation. We will see you soon, and don't forget to stop sepsis and save lives. See you soon.